Hi, this is Ashish Atreja. I'm CIO and Chief Digital Health Officer at UC Davis Health. I'll be talking today about engaging patients on GI healthcare using computers from wellness to chronic disease management. We are seeing an enormous change from volume to value-based healthcare and from provider-centric to consumer-centric care. And that has been driving a lot of the digital transformation we've been seeing over the last few years. And everything has been catalyzed by COVID. So we're going to see how GI as a society, GI as a specialty is getting transformed using digital technology, with the major levers being value-based and consumer-centric transformation. To allow this transformation to happen, we need to leverage things which are beyond currently what we have, beyond EHR. And that's where we need to leverage the field of digital medicine. And digital medicine goes beyond just telemedicine or one-to-one visits. If you can see, telemedicine still requires a provider on the other side of the table. So it's not scalable to the extent as pure digital health technologies can be, which can provide one-to-many care. For example, if you create a video of yourself explaining bowel preparation to the patient, you can disseminate it to millions of patients without spending extra time. What if you can stitch that video in a text messaging based auto reminder to the patient so they automatically get the right information at the right time without you having to speak to the patient? That's what we mean by scalability. And that's what digital medicine like apps can do. So I'll be focusing my conversation today on digital front door and navigation for procedures, digital apps for monitoring and digital therapeutics, and also on decentralized trials, which can scale one-to-many care and one-to-many research. At UC Davis, we have created a Davis Collaborative, or in short, Davis Collab, so we can really transform the care across all specialties in digital first and data first strategy. And our goal is to partner with industry leading pharma, industry leading healthcare IT, and innovation startup ecosystem to really co-ideate, co-create, co-validate, and co-transform healthcare. And our vision is we want to provide a digital Davis experience, a unique experience, not only to the consumers, the patients and their families, but also to our providers and nurses. So we are not able to provide a better experience, better outcomes, but also save time for physicians and nurses while they're providing care. To provide the context, first I'll share some use cases around digital front door and navigation, digital monitoring, digital therapeutics, and decentralized trials, which are beyond the field of GI, which is across other service lines. Because a lot of our learning has been what's happening across in medicine and how do we fold it into the field of GI to create the subspecialty called as digital GI. So this study from JAMA is an example of digital front door and a text messaging solution where just by one directional text messaging reminders, it was shown that LDL-C levels were significantly reduced in those who got the intervention versus those who not, with a relative risk reduction of 0.61. And majority reported this digital front door text messaging was useful, easy to understand, and appropriate in frequency. It's a very powerful study showing just text messaging alone can actually have such a big impact on improving behavior and outcomes. And this is the example of digital monitoring. WellDoc was the first app to be approved by FDA for monitoring, and it started the whole field of digital therapeutics, where basically a Bluetooth connected glucometer was able to provide real-time feedback to the patient when they tested their blood sugar. And based on real-time feedback and intervention, we found many patients in the randomized control trial had a better control with an average increase of 1.2% better A1C over a 12-month period. So this remote monitoring is becoming a key concept in digital health and engagement with the patients. And this example is how you can combine mobile apps and digital monitoring with AI and automatically create suggestions for the patients and the recommendations for the patient. Somatics is an Israeli company which has created an AI-based biomarker for smoking, Basically, based on how the accelerometer and gyrometer work on a wrist device, they are able to distinguish using those algorithms if the person is smoking versus the person is combing the hair or doing a shave. And through that, they can give a recommendation back to the patient that, hey, you are smoking and you are in a hospital. Are you tensed or something of that nature? So this is how we are seeing embedded AI working within apps and digital therapeutics. And this is the example of decentralized trials where instead of having a coordinator call the patient and approach them, the patients automatically get a text message. And through the text message, it walks them how to enroll into a clinical trial. And we leveraged this tool during the time of COVID and had 15,000 people enrolled within the first week, with overall 55,000 people enrolled within few weeks. Something that we have never been able to do it before with manual coordinators. This text messaging alerts for reminders leading to video visits is a very good example of a digital front door, which I would believe majority of the GI sites should be having within the next couple of years, which is completely automated and gives the patients an option of what kind of visits they want and automatically schedules it for them. But you can go beyond just plain text messaging or digital front door to actually put clinical intelligence on it and create what we call as a digital navigation, which walks the patient from point A to point B, such as completion of a procedure. And we know there's a big need for that in GI because we have a lot of revenue leaking, a lot of patient outcomes which are poor because of lack of guidance and navigation during procedures such as colonoscopy. And we believe an average GI practice lose around $1 million a year just because of poor no-show, poor bowel prep, as well as patients not coming back for repeat visits because of the poor experience they had in navigation. We also believe a lot of the patients who could have got for colonoscopy never are scheduled for colonoscopy because they are not forwarded or recommended after a positive fit or Cologuard. Many of them lose traction and don't know colonoscopy is the next best step. So just a little bit nudge can actually get them towards the colonoscopy as well. This is an example of what is the current state of the art. We just give a paper to the patient for colonoscopy, and 50% of the patients either do forget the paper by the time they leave the practice or by the time they reach home, or they cannot find this paper when the time for the procedure comes. We need to be doing better. So how can we completely change the game of digital navigation and digital experience? By creating a tool for the patients where they automatically get timely alerts like text messages on their phone with customized education for their bowel prep. So this is something that's existing today, and we have been leveraging both at Mount Sinai and starting to leverage at UC Davis, as well as many other hospitals. As you can see from the slide, the patients get a customized alert which reminds them of the appointment. It drops actually right into the iPhone. And then they get customized alerts what to do 10 days before, 7 days before, 2 days before, and how to take a split prep with videos and instructions. And once the patient is done with the procedure, they get a referral to say, hey, how was the experience on a net promoter score? And if the experience was good, they're automatically referred to physician branding sites like Google, Yelp, Healthgrades, and all. And all the trajectory of the patient, right from pre-procedure, procedure, and post-procedure, is tracked in a live dashboard. So if patients are not engaged, you can nudge them through a text, video, or a phone call. You can even combine all the patients who have not responded and give them a nudge with driving directions or parking directions, just to remind them about the procedure. So what is the evidence that this kind of digital navigation really works? So this is the success story from Arizona Center for Digestive Health. And this is through the partner of AGA in digital transformation, RX.Health. And they were able to show there was 24% improvement in bowel preparation. There was 50% reduction in aborted procedures and 92% patient satisfaction by going through this digital navigation, which was completely automated for the patients. Other sites have been able to show very high net promoter score and patient satisfaction with this. At Sinai, we are reporting the results in this year DDW, showing that engagement with digital navigation program is the strongest predictor for procedure completion in colonoscopy, where people who are engaged high in digital navigation are around 4 times more likely to complete colonoscopy versus those who are not. In partnership with AGA, that program has now expanded to procedures beyond colonoscopy to include all endoscopy procedures as well as pediatric GI cases. Let's talk about the top digital GI use case, especially on digital monitoring and digital therapeutics. Treat to target is a great goal for IBD, but no one knows how to do that at a population level. And we believe remote monitoring at home is essential to achieve treat to target, because how can we achieve treat to target without knowing symptoms of our patients at any given time? We do know if we are able to provide proactive care, we can not only improve IBD patients' disease control and quality of life, but we can also reduce a lot of unnecessary disease utilization. And this evidence has been replicated across many other diseases, including CHF, COPD, diabetes. So can we do it for IBD? So this is part of a big collaborative that's happening right now, where we not only want to do it across the IBD population, across Cleveland Clinic, Mount Sinai, Northwestern, and UC Davis, but also try to reduce digital disparities. So we have a digital monitoring app called Health Promise, and that's linked to a physician dashboard. So all the data what patient enters on monitoring is real-time available in a physician dashboard linked to the electronic health record. Our earlier results based on NIH K23 trial showed that by doing this, you can actually improve the quality of care metrics for the patients in the intervention arm versus the sham arm. While we know there was feasibility and high adoption among IBD patients, now we are planning in partnership with multiple other sites nationally to actually make it available to all our IBD patients and see the impact among thousands of IBD patients in improvement in their disease control, quality of life, as well as preventive screening and mucosal healing. This screenshot shows how this digital IBD app formulary is available right within Epic or EHRs. So physicians and care teams can prescribe this app directly from EMR, very much like they can prescribe a medicine or order a lab result. And the data from the app, what it shows is comes back like results very much into the Epic system. And so we can actually act on it exactly like remote monitoring the patients. And really, this is validated data, very structured data, which comes back and can create decision logic as well. I know there are other topics in this session on AI, so I'll just briefly touch upon AI. This was something we did from natural language processing, linked with machine learning, where we can, from pathology, automatically identify patients with dysplasia and automatically then recall them. And we found 30% of patients with dysplasia or advanced adenoma did not have a follow-up colonoscopy. So we can now extend it through pathology nationally for any EMR. The other part of data science AI is the more the data, the better it is. We already have a University of California-wide consortium, which has the data from all our EMRs combined together, around 10 million patients. So we can actually create logic for digital biomarkers, IBD prediction, all of them combined across all the 5 UC sites. And as you may be seeing, there's so many cases of AI, especially from computer vision, where polyps can be detected, where advanced polyps can be detected versus others. You can do real-time histology, and using AI, you can do self-propelling endoscopy as well. The last use case I want to share is how we can do decentralized trials, and that can automate not only care, but also research. So not only we can approach patients automatically through the EMR, but we can engage the patients and bring them back for video visits and monitoring while they're at home and conduct entire clinical trial from home, or we call it blended trial, where majority of the trial can be done at home. We're already working with AGA to automate patient-reported outcome collection across 65 sites nationally for fecal transplant registry, an example of how the follow-up can be conducted automated using patient-reported outcomes and mobile health technology. We actually used a bot, a clinical trial recruitment bot, to real-time reach out to IBD patients and reach out to 1,309 patients at 8 a.m. in the morning. And by 5 p.m., 206 patients agreed to be recruited in a clinical trial, a number we had never seen before using in-person engagement. Fortunately, all the examples I have shown are now bundled into a toolkit for GI, and through AGA and its partner, they are making I just want to end at this note. Digital GI is GI. Are we ready to transform GI practice and research today? And I'm sharing